Hello and welcome to this interview today with Dr. Craig Friesen from the University of Missouri, Kansas City. And we will be talking about food allergies and functional abdominal pain disorders in children and adolescents. Craig, thank you so much for being here.
Well, thank you for inviting me.
Craig, why are functional abdominal pain disorders so common in children and adolescents? And do we know how these disorders are associated with food allergies?
Yeah, so let me sort of break that into two parts. So absolutely, we know they're common, but the $1,000,000 question is why? And there really isn't a known answer to that. And part of that's from the complexity. And so almost, every survey in every country that's been done over 7 decades come up with numbers that approach 20% of all children at any given time are having abdominal pain. And the great majority of those kids will have what used to be called a functional GI disorder, now called disorders of gut-brain interaction, or DGBI. We'll come up with another acronym in a couple of years. But the DGBIs themselves are really conditions that are certain specific symptom constellations where there isn't a classically defined disease, but it doesn't mean there's not biologic contributors. And so the complexity comes from most people view these through the biopsychosocial model, which says, just as the name implies, there's biologic, psychologic, and social factors, and probably all of those operating in everybody who has chronic pain, just because the systems are so interconnected. But I think we've come to an understanding that there's really 4 main interacting systems: neurologic, endocrinologic, immunologic, and psychologic. And so when we start getting why do you have it, the complexity of it to start with makes it difficult to come down to one sort of factor of what's there. So I'm not sure I can answer the question except to say that we've gotten more and more information about the biologic, psychological, and social aspects of this, but we still have quite a ways to go to really understand some of those interactions and why populations of kids seem to be so consistent over time and place with these high prevalences. If you permit me to wax on a little bit, I'll take on the second part of that question, which I think is a way more complex one of the role of allergies in this. And there's some things that we know. One is that there's a lot of overlap in lots of prevalent studies that have been done in referral populations, general populations, adults, children, and pretty much all of them find that there's an overlap between either irritable bowel syndrome or functional dyspepsia, the 2 main DGBIs, and allergic diseases, asthma, allergic rhinitis, eczema. And so it raises the possibility that there's some common pathophysiology or possibly cause and effect between them. We also know that DGBIs and allergic reactions share a lot of sort of biologic aspects to them, in that for both of them, obviously for allergies, mast cells and eosinophils are important, but there's now a huge body of data implicating both of those cells in DGBIs associated with abdominal pain. In fact, a student recently did a review for the mast cells. There's over 90 published articles implicating mast cells in these processes. So it's not a small body of data. And we're over 40 now, at least, of the ones we could identify for eosinophils, most often in functional dyspepsia. So there are a lot of common overlaps. And another one is stress, the role that stress plays for both conditions. And so, there's reasons to believe that there's overlap, but whether or not it's, cause and effect or, the epiphenomenon, I don't think is quite as clear. But there's some challenges in trying to sort out food allergies, I think, in patients with GI disorders. And the first is that meal-related symptoms are common in this population to start with. So irrespective of what the food is, just eating itself creates symptoms in a large portion of folks. So increase in pain with eating, increase in nausea with eating. And for functional dyspepsia, 2 of the criteria are eating specific. One's early satiety and the other is feeling bloated after a normal sized meal. So there's this baseline of problems with eating that occurs in the first place. Then on top of that, in one study that came out of a group at Baylor, they found that over 90% of kids would identify at least one specific food that they viewed as worsening symptoms. Inside our institution, it runs around 70% when we look at it, but it's a high incidents of these kids saying, I have a specific food that sets it off. Those may not always pan out when you actually start to investigate kids and do things to look at what sets off symptoms, but there's at least that perception. And so leads to the question of why does that specific food set off symptoms? And I guess traditionally, classically, we've divided this into three groups. One is those allergy related symptoms, which there are the immunologic ones, then the non-immunologic ones, which we call food intolerances. So like lactose intolerance, fructose intolerance, those things. And the other one that's been, I think, being increasingly recognized is this sort of hypervigilance and anticipation of symptoms that kids can get when they view that specific food. And disordered eating patterns based on beliefs about food are now recognized as being a fairly common occurrence in these, and are probably related to a stress response, anticipating symptoms from having had that food. So, so be nice. We could just say, yep, that's an intolerance. And honestly, traditionally, we have done that. Oh, lactose, that's an intolerance. Oh, milk allergy, that's obviously an allergy, it's immunologic, but it's those lines have really gotten blurred. And I guess to give you an example, patients who have lactose intolerance or fructose intolerance, the malabsorption of it actually is a poor predictor of whether or not they're going to have symptoms. For something we've always believed, that's a malabsorption. And lactose in particular, another group associated lactose intolerance with increased lymphocytes in the colonic mucosa. We published a study, I don't know, a year or two ago, showing increased eosinophils in the colon of patients who are lactose intolerant relative to controls. And so probably the distinction really becomes, does that food act as an antigen that directly stimulates it, or does it do it indirectly? Because these malabsorbed sugars, we believe, probably change the microbiome, which then changes the permeability of the gut, so-called leaky gut, which then exposes the immune system to a lot of antigens that are in the lumen, bacterial or food. But in the end, you either directly or indirectly, and which may not be important clinically, actually activate the immune system within the gut, which may be what causes the symptoms. And so it gets cloudy. The other part of that is the prevalence of food allergies in these patients is also another kind of quagmire, if you would, trying to sort out. And and partly some of that is the tools that we have. But those patients who get systemic symptoms, so they eat a food, they start wheezing, they break out in hives, certainly if they have an anaphylactic reaction, are pretty easy to recognize at the end. You may not know exactly what the food component was, but they reacted to something, and this is going to be an allergic reaction. But it appears to be likely that most patients who have immunologic reactions to foods have only or primarily gut symptoms. And that group is a tougher one. And that's tell you, I've been a debate had with allergists forever. GI docs have always believed you could have an allergic reaction to food. At least allergists that I worked with said, nope, you don't have a systemic reaction. And we have no clear evidence that this is an allergic reaction. And there's probably with information truth to both sides of that, right? So, but there's been some what I think are fascinating studies using colonic allergen provocation tests. So it's basically doing the equivalent of a skin prick test on the mucosa in the stomach or intestines. And so basically go in, they inject the antigen, look for a wheel and flare reaction, and then biopsy, and can show that yes, there's IgE will stain, but also increase in mast cells and eosinophils in those areas. So you get this acute reaction to it. And when people have identified foods by that, only a very small proportion will get picked up by skin prick tests or food-specific IgEs. And so it looks like it may be something that is an IgE reaction in the gut, but has no systemic component. And so our normal testing that's convenient, because obviously I'm not in any way advocating we start doing these tests and everybody who has abdominal pain, let's go inject antigens. But it is there. I think the other thing that complicates this a little bit, or in some places gives you greater clarity, is that environmental allergens look to be important in these patients too. So as you breathe dust, mold, pollen, all get in saliva, you react to them. And been some great studies done specifically with birch allergens. And patients who are allergic to birch, if you go in and biopsy their intestines during birch allergy season and then compare it to out of the season have a significant increase in eosinophils and most develop symptoms. Well, birch, like a number of other ones, also cross-react with a number of foods. And so those allergies may be an indicator of, okay, here's some foods to eliminate, even if we don't have a great test for them. And one of my colleagues, Dr. Sherman, who's a psychologist that I work with, did a study. It's called Momentary Assessment, but basically you have kids get on and report symptoms 4 times a day into a computer thing, and they put their exposures. And then you can time lag it to see what happens after different exposures. And so you can get basically estimate the effect size of poor sleep, of something stressful happen. And one of the measures she looked at was just pollen measured on our roof in our community. And when we looked at it, the sleep and stress were strong, had strong effect on both pain frequency and intensity. But once you looked at pollen, it was equal to those other two. And so there's this environmental factor to this that I also think gets challenging with it in this patient group, where if they have one allergic condition, they're probably likely to have another. So that's there. And I think the IgE stuff is probably still sitting out there, and it doesn't even touch on the cell mediated, which we believe is, or at least where we recognize is more often in little kids, like the FPIs and those kinds of things. And then the whole sort of literature that still exists around IgG reactions as opposed to IgE. I believe pretty much every major allergy organization has come out saying that doing IgG testing is inappropriate, and absolutely they should have. There isn't the evidence there, but there also isn't evidence to completely discount it either. Is part of the problem, and there's still enough studies out there to say, okay, maybe there's something there that needs to be sorted out. But again, it's using symptoms as part of it, which have a lot of factors going into those, especially when they're GI symptoms across the biopsychosocial realm, having not a great way to identify specific food allergies in these patients, or at least things that we no longer believe are terribly sensitive, make that question hard to answer. But I do think we feel pretty comfortable saying that mast cells and eosinophils are a common part of the process of what happens in functional GI disorders, or DGPIs, and that allergens have to be considered at least one of the major triggers, probably along with infections and stress in these patients. So that's a long way to get back to, there's just a lot that we don't know. But I think there's enough evidence to say that it's at least overlapping physiology, and therefore treatment may be similar between the two, and that there's for sure going to be an interaction between the two.
Do you maybe also have some key pieces of advice to give to practitioners who may be watching, that are working with children and adolescents suffering from functional abdominal pain disorders and/or food allergies?
Yeah, I'd say a couple things, some management things, but one in terms of causes. And I think that stress is a terribly important. Frankly, it's important in all diseases, right? Asthmatics wheeze more, diabetics run higher blood sugars. Every GI thing gets worse. But DGBIs are pretty highly associated with stress and anxiety as a negative impactor on those. And there's studies, both GBI patients who have eosinophils and allergy patients showing that stress interventions actually change the course of that disease and severity of symptoms. And some of that's going to be a significant interaction directly from the hypothalamic pituitary axis, so CRH, directly activating mast cells. So that's part of why CRH is a target. But it's also, as I had mentioned before, the epigenetics of this. There are those interactions with stress and changing the intestinal barrier, increasing antigens. And so there are a lot of mechanisms for it. And one of the studies I love to quote, which is almost 25 years old now, from Dr. Santos, is they took adult patients with food allergies. And they went in and basically put 2 balloons in so they could isolate part of the intestines, put their food allergen in there, and then measured histamine and tryptase output in there, luminal. They then took those same patients and put them under physical stress conditions and measured them. And the tryptase and histamine output were virtually equal. So what it tells you is, okay, if I find a food allergen and I eliminate it, but that person then gets put under stress, I'm going to see the same reaction. So I'm probably not going to see an improvement in symptoms. And so I think clearly whether you're identifying one or the other, and our belief or approach is really that identifying as many targets as you can across that biopsychosocial model and intervening as many as you can gives you the best momentum and outcomes. That's seems empirically or intuitively, obvious, but there's not a lot of empiric data, but there is some for asthma, and there certainly is for kids with eosinophilia in their gut to suggest that if you add relaxation techniques, they get better. And in fact, in our eosinophilic kids, one of the studies we did was compared the medications to medications plus biofeedback assisted relaxation. And we did the relaxation training, those kids got better in about half the time. So everybody got better, they just got there quicker. And so I think it's part of the advice would be to think of these more broadly than just here's the biology of functional dyspepsia or irritable bowel or frankly food allergies or any other food or food intolerances, and say, okay, there are a lot of other factors here that interact, and to consider those as part of it. I would also say that it seems unlikely that saying let's do broad allergy testing in all kids with abdominal pain and with the hope that we identify the cause and we can eliminate it and therefore we make this go away is not likely. And I think that's because of all the other factors that go into creating symptoms, much like what Dr. Santos had demonstrated in their studies, especially when people have started doing more IgG panels because they advertise on TV. So it's not uncommon anymore, at least here, for someone to come in with the panel. They've paid a couple $100 to find out what foods are really causing the problem, with tons of positives. And I think it's true with IgE panels also. It's unlikely that those are going to be things that in the end is, okay, I eliminate these foods and they're there. And I think that's actually the clinical experience that people have. What it really does is probably promote more disordered eating, because people now believe, here's my foods that are a problem, whether they are or not, and potential for some malnutrition. So we see kids on some pretty bizarre restricted diets that don't meet their nutritional requirements. That's there. But having said that, I do think those patients who get systemic symptoms, so wheezing, hives, etc., and those people who develop oral allergy syndrome type symptoms from foods should all be sent to an allergist. And I think it's helpful. I do think, as a GI doc, which is what I am, that we probably aren't the people who should say, oh, let me do some allergy testing, and particularly just ordering big panels of stuff. I think they need to go to an allergist who says, okay, let's look at, sort of the pattern of this. Let's make some decisions and test for the right stuff and manage that. But even those patients, it shouldn't be just refer them and forget about them. I think you have to remain in collaboration, because what you're really doing is asking the allergist to deal with the biologic aspects of it, but you need to be ready to say, okay, let's make sure we're doing a full court press on the other things. But I think those are the patients that should be evaluated, and should be evaluated by somebody with expertise. Speaking on behalf of the GI community, or to the GI community, if you would, and if it gets identified, obviously the pathway is pretty simple. Here's you eliminate it, right? To the degree you can, or take things to desensitize them, depending on what it is. But ultimately, I think we can do a better job of saying there's a process that's potentially allergen related. Let's do the best we can in identifying them. But oftentimes where you end up is using strategies to either decrease antigen exposure, so things are going to change that leakiness, if you would, of the gut, which are really altering the microbiome. Or we're going to be looking at things, how do we use mast cell stabilizers to try to decrease reactions and potentially even block an allergic reaction to a food, provided they don't have systemic effects, or strategies to use medications to block the effects of downstream mediators. And I think it's become clear that leukotrienes are probably an important pain mediator, but particularly histamine in the gut is an important pain mediator, but also maybe the most important molecule in terms of sensitizing those nerves in the gut and setting people up for long term. And so, a lot of the treatments that are used for allergies are probably quite beneficial in this patient group too. So.
Great. Craig, can you also share with us where your next research priorities lie and where you see the need for further research?
Yeah, I think, well, I hope those two overlap. So, the biggest need is for us to really get a better understanding of integrated systems. So, and when I talk about those systems, it's, that those interactions between the psychologic, endocrinologic, neurologic, and immunologic systems. And sort of how do we define, if you would, a new definition of what a phenotype looks like across all of these, but understand those interactions. And when we throw a treatment at, how do those systems sort of are altered within that, and which things are beneficial or not. So obviously we're getting to whole person system-based research, and that's really where I've been heading with this. So we're actually have put together a consortium really to try to look at some of this stuff very specifically that involves people. So I've always said it's way easier to classify GI docs than it is patients. So, you can classify GI docs as, there's the person who thinks it's all motility. There's the person who thinks it's all immunology and inflammation. There's the person that thinks it's all psychologic, et cetera, et cetera, et cetera. But patients don't do that. They're all of the above. And so we've come to belief that everybody's right, and we need to figure out how this works together. So we've actually put together a group of people who have beliefs across that, and are going to take a multi-omics approach to this to try to really understand, okay, so defining them from physiologic tests, but also, using multi-omics approach. And, my own personal goal that fits within this is really, one, trying to figure out a good biomarker for eosinophils in the gut if we can. We found markers before, but ones that don't change as the inflammation changes, and so they're not helpful. And so we've been taking a metabolomic pathway towards that. And then the other thing that's big in my list is really trying to understand the effects of stress on the epigenome, how that affects the immune system and interacts with the microbiome, and particularly microbiome metabolic products in this patient group. But it's really, I think, time for us to start tying all of this stuff together. And I think from an allergy standpoint, as I would look at this, I look at it as, once we can define a better model. So the biopsychosocial model is fairly loose. It's hard to test. It's a great way to talk with patients, but it's not a great way as you're trying to put science and take all of the data that's been created and put it together in a model. So that's really where we're trying to go with this. With the idea then, okay, in therapeutic trials, let's really understand what happens in a person. And I think same thing would happen if you get an allergen. What really happens across all of these systems, and let's not limit it to just what happened at an inflammatory level, because we believe that's where it's most important. But what effect does that have on the brain? What effect does that have on stress responses in the body? What effect does that have on the microbiomes? We know stress in people affects the microbiome just as much as the microbiome affects stress. And so that's sort of where my passion lies at this point in time, is really trying to understand how what that model looks like. Are there certain clusters of things across these that we can define certain patient groups? Do they respond differently to either exposures or to treatment trials? Just some minor ambition within that, trying to understand the entire human being in one fell swoop. But there's a bucket load of data out there around mechanistic stuff with this. And I had a student who may go out and start collecting anything that was mechanistic and interactive, and he printed them all off, and they reached to my waist. So it felt like, there's enough out there for us to start trying to integrate all of this stuff and take everybody's view of the elephant and try to get the full picture of that elephant.
Greg, thank you so much for all your answers, and also for taking the time today, and best of luck with your further work. Thank you.
All right. Well, thank you. I enjoyed, and I appreciate being invited.